Good evening, everybody, and thank you for attending our webinar today. It's a little bit late, but it will be light as well. I'm Dr. Omnia Hamam, the consultant ophthalmologist from Zayed Military Hospital. I'll be moderating this session today about the medical management in glaucoma. I'm the head of the scientific committee of Emerson Ophthalmology as well. Um, I'm so happy today to introduce two of our brilliant colleagues and well-known names in glaucoma. Our senior, Dr. Mohammed Hisham, consultant ophthalmologist in Maghrabi Hospital and the medical director of Maghrabi Hospital, Abu Dhabi, Dubai, and Cairo. Dr. Mohammed Hisham always, make me smile when I'm seeing him, his positivity all the time, and I'm enjoying all the time his talks. And as well, I'll introduce Dr. James Bacon, consultant ophthalmologist in Cleveland Clinic. And he's also the clinical assistant professor in Cleveland Clinic Learner College in Ohio, USA, and the program director of residency program in Cleveland Clinic. And we can start with Dr. Mohammed Hisham. He will talk today about the medical management in glaucoma. Dr. Mohammed Hisham.
Yes, I will share my screen. Good evening all. I will just focus today on the management of primary open-angle glaucoma. As far as the primary open-angle glaucoma, once the angle closure glaucoma, once SIAG is done, we can just consider it as an open angle and just go with the same steps. Glaucoma, as we know, is one of the major cause of blindness all over the world. Studies show that it ranges from it's responsible from 7 to 14% of blindness all over the world. It differs according to the region, developed to developing countries. We should think of glaucoma as stations, like these metro stations. It looks like a process going along a horizontal timeline from the time of detection. Glaucoma is detected when signs suggesting the disease, like suspicious optic disc, high IOP, or if the patient has a big history of large or strong history of glaucoma. So after confirmation comes the period of follow-ups, and this will be lifelong. In the first few years after diagnosis, it's very important to assess the rate of progression and to detect who has the rapid progression. In this chart, if a patient comes to me, we have three categories: ocular hypertension, glaucoma suspect, and established glaucoma patients. If the glaucoma, if his ocular hypertension, we have to consider what risk factor does he have: increased IOP, big cup disc ratio, thin cornea. And if he has low risk, then we can reevaluate every 12 months. If he has high risk, we can evaluate every 6 months. If he's suspect, we should consider again the IOP and other risk factors and evaluate from 6 to 12 months. If he established primary open-angle glaucoma, we should first decide what is his targeted IOP that we want to reach. Most probably 30% reduction of the primary IOP that we see him with first time, and then follow him up closely in the first couple of years. If after this year we found out that he has stable under this treatment, we just can evaluate him every 6 months. Or if he has progression, we have to change our target IOP, make it lower, and change medications, make it more aggressive, and decide new baseline of IOP, and then evaluate maybe in a shorter period than the 6 months. How to diagnose the glaucoma? Usually diagnoses have been through two things: structural and functional. Structural by examining the optic disc head, its rim, and the nerve fiber layer by the OCT. Functionally, usually we depend on the visual field. So after confirming the diagnosis, we have a period of 2 to 3 years that we have to study the rate of progression. So we cannot depend only on following the IOP only, or doing 2 consecutive visual field and OCT examination and then decide that this is stable or unstable patients. We have to do more than 2 examination, 5 to 7, ideally 5 to 7 tests in these 2 years to decide if this patient has a progression or no. And accordingly, we can decide how to manage him. Trying to move. So, sorry. So in detection of the progression, we depend mostly on the optic nerve head cup disc ratio, in addition to the visual field. But in analyzing visual field, we have to differentiate between the trend and the events. The trend, like on the right side, there is a steady line progression of the optic disc cupping, while in the event there is a sudden change of the optic disc over a certain period. And as well in the visual field, the progression here, if there is a trend, there will be a steady progression of the visual field. In the trend and the event, there will be a sudden change, like on the left side here, a sudden change of the optic disc. We have to assess the functional progress. Like in this patient, we have an optic disc, but just by looking at the optic disc, we cannot, over years, we can see that it's nearly similar. We don't have lots of changes, but looking at the visual field here, we can see the progression. So by following the visual field, we can see that this patient is progressing, and we can document it actually that he is progressing. It's well known that the treatment can significantly change the rate of progression. This table shows that rates of progression in glaucomatous visual field in treated eye and untreated eye ranges from 0.3 to 0.8 decibels per year. In this Swedish study of more than 500 glaucomatous patients showed that the mean rate of progression for the treated glaucomatous eye was 0.8 decibels per year. So what is the rapid rate of progression? What is the figure that we say that this is a rapid rate of progression and this is a slow rapid rate of progression? First, information taken for the visual field is measured in decibels if we taken the mean deviation, or in visual field index. In general, the visual field index is related to the mean deviation, like 1% per year loss of visual field index is equal to the 0.3 decibels per year loss of mean deviation. So rate of progression equal or more than 3% per year of visual field index, or 1 decibel of mean deviation, this leads to significant, this is a rapid rate of progression, and this will lead to a significant loss of quality of vision regardless to the patient's age. This study done by Brinkston et al. Tested the ability of examination to examining the linear trend to predict the future visual field loss. Linear trend was derived from 5 initial visual fields and was used to predict when the visual field, the final visual field index of a series of 11 visual field over 8 years follow-up. 70% of these patients had a final visual field index within 10% of the estimated final visual field index. We give examples like this patient who has slow rate of progression, and there is no risk that his quality of life will deteriorate. So here we don't have to change the medications, but in this patient, the rate of progression is rapid, and here we have to intervene and change the medication and change his IOP to slow down this slope, because the visual field will lead to a great loss within a few years. But we have to be aware of, in examining the visual field, that some visual field changes can be related to other reasons than the glaucoma. In this case, you can see the beginning of the visual field was stable, rate of progression was stable, and then at one stage we had this homonymous quadriopsia, which is related to a stroke. Actually, it's not related to the glaucoma. And if this happens, we have to redefine our baseline again. After this event, we have to see the new baseline to follow up in the future progression. In this study by Fukushi et al. Shows the relation between the intraocular pressure and the progression, the rate of progression. The higher the intraocular pressure, the faster the rate of progression. In this Canadian glaucoma study, this figure is an example between the change of IOP and the change of rate of progression. The baseline of this example was of this study was 4 decibels mean deviation. The mean IOP that was planned was 18 millimeter mercury after reducing 30% of the essential IOP. With such IOP, the rate of progression was 0.36 decibels per year before the first endpoint. After the first endpoint, a new target was set to further reduce the intraocular pressure by 20%. So the IOP target was 14.8 instead of 18. And with that pressure, the rate of progression reduced from 0.36 to 0.11 decibels per year. And this shows that the reduction of the intraocular pressure will reduce the rate of progression. So with the same example here, it's very difficult to assess only from the optic disc photography how this is the progression, especially in tilted disc and in advanced patients. So, but luckily enough, we have a different imaging tools now that can evaluate the nerve fiber layer of the optic disc. One of them is the HRT, which measures the changes of the retinal height. And the second one is the OCT and the GDX, which can measure the peripapillary retinal fiber layer thickness. And we have the spectral domain OCT that can measure as well the macular ganglion cell layer and the inner plexiform layer thickness, which becoming very important data to evaluate the glaucoma. When measurements are taken several times, alignment is very important to measure the same area. HRT does this automatically. So 2 main measurements are done with HRT, and the 2 main things that we can get from the HRT are the rim area and the retinal height. In glaucoma, tissue loss will produce decrease in the retinal surface layer, mainly in the optic disc, optic nerve head. An event of change can then be recorded as a reproducible decrease of a group of pixels. These figures from the OCT Sera software calculates the events and the trend analysis for the change of the retinal nerve fiber loss thickness, layer thickness. Areas colored by red, maybe in the second, because I cannot use my pointer here. Areas colored by red presents an event of retinal nerve fiber layer thickness decrease. This is very useful in glaucoma follow-up as it shows the specific bundle affected. This is also seen in the thickness profile map. You can see here that the inferior retinal nerve fiber layer thickness trend is negative and fast, confirming the progression. We have to consider again the normal changes that can happen to the structure of the optic nerve. There is normal age-related normal structures changes that needs to be taken into consideration. Many structural parameters are not age adjusted. This means that all changes seen over long periods of observation may not be related to glaucoma alone, but can be related to the patient's age. In glaucoma, structural changes can be documented as significant if the neural rim area decreases 3.5% per year, or more in optic nerve photography, or if it decreases by 0.0053 to 0.0123 square millimeter per year, or 1.24% per year in HRT, or in OCT in time domain 0.72 microns per year loss, or in spectral domain 1.26 to 2.12 microns per year. How many OCT should we do per year to decide the progression? In this study, the frequency of test and the time needed to detect the structural progression with spectral domain OCT has been calculated. With 2 examinations per year, a structural change of 2 microns per year can be detected in 3.5 years. If we want to shorten this period to 1 year only, the number of tests need to be increased to up to 4 tests per year. More than 4 tests per year, this is, it will not give us more benefits, actually, it would be useless. We have something called the floor effect, like in this patient who has inferiorly, we have a very thin nerve fiber layer, and you can see there is no progression in the inferior part of the optic nerve, while in the superior part there is progression, because in the inferior part we reach the advanced changes that it cannot be documented anymore. So after like 45 microns, we cannot depend on the OCT to detect any rate of progression. Sometimes even the cup risk ratio cannot be determined. So in the new OCT, it can actually determine this ratio. This photo shows a spectral domain OCT and can accurately determine the exact position of the Bruch's membrane opening, which is the outer limit of the optic disc head. Without this, we may underestimate the cup disc ratio. So how frequent should we do the glaucoma test? There are recommendations for the frequencies of the visual field test in different guidelines. As we can see here, it differs according to the degree and the stage of disease. Moderate and advanced stages needs more frequent tests and maybe more than every 3 months. And longer interval can be planned in cases when there is early damage or there is no progression. Same here. So if the initial 2 to 3 years, 6 visual field were done and detect progression, if the progression is noticed, like if there is hemorrhages of optic disc or the IOP is not controlled, shorter interval should be needed. And otherwise, if the reverse will happen, otherwise, if there is no progression, so we can just prolong the intervals. Rather than every 3 months, we can make it every 6 months or even more. Each patient needs different management. We have to be careful when setting initial target of IOP. After this 2 to 3 years, assess the rate of progression. If progression is stable, we can increase the intervals of follow-up. If the progression is noticed, if it's noticed, we need to set a new progression, a new target IOP, and be more aggressive with the treatment, and maybe have shorter examinations. Sometimes the structural progression precedes the functional, the visual field, like in this patient who had inferior temporal bundle affection without the visual field showing the same, except after years, like from 2005 till 2009 when it began to show the changes. So it means that this patient has changes detected 4 years before, and the vice versa can happen. Visual fields sometimes detect affection more earlier than the OCT. So in the cardiovascular surgeon, they know that reducing the blood pressure by a small amount, like 2 to 4 millimeter mercury, can reduce the strokes and cardiovascular. Can this happen to the glaucoma? The early glaucoma management trial showed that this is really true. And even 1 millimeter mercury reduction of IOP leads to 10 to 13% decreased rate of progression. And all the other trials show the same, about the same figures. This is a actually very useful graph that we used to have before the electronic medical records, plotting the mean deviation against the patient's age to detect the progression of the disease. The green area usually denotes the normal field. The orange is the effect. There's damage, but it's not blindness. And when going to the red, there's blindness. And our aim is just to keep the patients from crossing this curved black line, and to stop the patients from going from the green to the red, at least reduce the slope of the progression. Like in this patient who has been newly diagnosed, and the rate of progression according to the to the data is like 0.6 decibels per year. So if we increase the IOP by 1 to 2 millimeter mercury, we'll have 10 to 20% more rapid progression. And if we reduce it by 1 millimeter mercury, it will be less by 10 to 20%. Same here, the patient, if he has this depression, and if he goes by the red line, he will be blind by the age of 77. But if we can reduce the IOP by 2 millimeter mercury, he will have more 7 years of vision to enjoy before going blind. Same here, so that the earlier that we intervene, the more years that we can preserve the vision of the patient. So in summary, measuring the rate of progression is essential to preserve the patient vision, and translating functional rate of progression into clinical management is easy and simple. Structural rate of progression can also be measured, but clinical decision should always be linked to the functional outcomes. And the relatively small reduction of IOP can have a clinical or significant impact on the patient's vision. Thank you very much.
Thank you, Dr. Mohammed. It was really so interesting, your talk, and so clear, direct to the point. I think I will ask you a question. When you set your target IOP, after the first visit, or you need like a couple of visits to set your target IOP?
No, you have a patient with high IOP, it's better to have a target IOP at that time, and then follow up later. Yeah, but be sure first that this IOP is not temporary, not like if he's taking steroid or is it temporary. Just be sure that this IOP is not, it doesn't have diagonal variations. So we have to at least to see what is the highest IOP that he's going, or the lowest high IOP. You have to just be careful when deciding actually the initial IOP, maybe first couple of days.
And you documented in your file, you write it down in your file, this is my target IOP, so.
Yeah, it should be. Yeah, it should be. So because everybody who will come later on have to follow this up. He has to know what was the initial, what the target, and if he's progressing with this target, how is the new target IOP, and so on. So the plans, we have the plan, it has to be written properly and clearly.
Okay. And when you reset again your target IOP after 1 year, 2 years, or if he's progressed?
Actually, we can set this after 2 or 3 years with the visual field and OCT follow-up, 2 or 3 years, and then follow this 2 to 3 years follow-up. And if you see the progression rapid, so we just put another target IOP and follow from them. This will be the new base IOP, and then follow up from this line. So 2 to 3 years to decide if we're going to change or not. If you reach target IOP.
Thank you, Dr. Mohammed. Maybe Dr. Yes, Dr. Mohammed.
No, I'm done. Thank you.
Thank you. So we'll continue with Dr. James Bacon for his talk now, switching. Yes, Dr. Bacon.
Yes, thank you very much. Thank you very much for chairing the meeting, Dr. Omnia, and Dr. Hisham. It's very nice to be with both of you this evening. So it's quite late in the evening. Thank you everyone for attending and for staying tuned in. I will try and share my screen and see if I can get my talk to work. Okay, can you see my slides?
Yeah.
Okay, perfect, excellent. So as I say, I'm James Bacon. I'm a consultant ophthalmologist at Cleveland Clinic in Abu Dhabi. Very nice to be with you, as I say, this evening. I think it's important for my talk today, the objectives are to talk about general medical treatment of glaucoma, and also to think about some case studies as well of patients I've seen with glaucoma as well. So that's the objective today in today's talk. It's important to know when to initiate treatment, when to continue medication, and when to add medication and when to stop medication, either because the patient requires surgery or because you're querying the original diagnosis. Also, it's important to recognize the vast majority of patients with glaucoma are treated medically rather than being treated surgically. This talk is my own work, and I have in the past received honoraria for consultancy work with Allergan. So I think this paper frames any of these talks quite well, and essentially it's a follow-up paper from an original paper in the 1980s looking at why patients go blind from glaucoma. This paper was actually done 30 years after the original paper, and really it was trying to highlight the reasons are still the same. So the reason patients still go blind from glaucoma are actually the same as they ever were, namely glaucoma is still undiagnosed. So in most population studies, approximately half of patients with glaucoma are not recognized or not diagnosed. Glaucoma is still improperly treated or inadequately treated. So either enough medication is not used or patients are not using medication properly, which goes on to lack of compliance. So often patients don't get hold of medication either because of financial reasons, or if they do use it, they're not using it properly. So these are all key issues, unfortunately, still mean our patients are going blind with glaucoma. So it's important when thinking about treating a patient medically, at the outset is to pause and make sure you're making the correct diagnosis. So fortunately, the majority of patients with glaucoma, the progression is quite slow. So take your time at the outset to categorize patients either as primary or secondary glaucoma, open versus closed angle. Beware of things like neovascular glaucoma. As I mentioned, angle closure glaucoma also often causes more severe disease, as do things like pseudoexfoliation and uveitic glaucoma. So if you see these sort of conditions, particularly in a young patient, it's important to take a bit more time with these patients, treat them more aggressively, rather than perhaps an older patient with lower pressures and open angles. So, try and categorize your patients and diagnose them accurately. I think it's also important to do no harm. So when you're making a diagnosis of glaucoma, don't just see a patient with a slightly raised intraocular pressure and think they require 3 or 4 bottles of eye drops. Often they may just need 1 bottle of drops to reduce the pressure, or there may be you can monitor them without treatment at all. So really, think about the systemic side effects of medication and also local side effects such as dry eye and ocular surface disease. I say individualize your therapy. So think about the ocular surface, think about preservative-free medications if that's going to help. Think about reducing the number of medications. So try to use combined therapies. If a patient's not using medication at all, just try and stop it completely. Think about previous glaucoma surgery. Think about asthma in patients, so don't use beta blockers. And also with uveitic patients, make sure their uveitis is also well controlled. So there's no point controlling the IOP if the uveitis is still uncontrolled. And as I say, beware of patients who are young or have got secondary glaucoma or angle closure glaucoma, because these patients often have a more progressive, a more severe progression of their disease. Spend time educating your patients. So from their point of view, they're using these drops every day, but they don't see any benefit. All they get is red eyes and having to put drops in once or twice a day. So educate them that it's about preventing progression of the disease. It's not about improving their vision immediately. It's about preventing further progression. Particularly if they've got one eye already damaged, you can say to them, you don't want the second eye to become like the first eye. So take time thinking of, explaining the disease to them in terms they can relate to. So rather than using medical terms, try to make it clear for them, talk about, preventing more sight loss, talk about driving vision, talk about contrast sensitivity or night vision. So there's lots of studies recently showing that even with mild or early glaucoma, patients have significant problems at night and also with driving at night, or even driving during the day. So even early glaucoma can affect a patient's daily life. Also be aware that most of us can't even complete a course of oral antibiotics. So getting a patient to use drops every day for years and years is quite a difficult sell. So always try and reduce the number of medications or reduce the number of bottles the patient is using by using combination therapies. Also, particularly in this country, patients will normally be with their family, so try and engage the family as well. If they have a nurse with them, engage the nurse with them as well to try and improve their compliance. I think another key thing is, rather than always adding medication, try and switch therapies. So if they're on a prostaglandin, which has had a very poor effect to their intraocular pressure, then switch to either a beta blocker or a combination of beta blocker with a carbonic anhydrase inhibitor, such as timolol with dorzolamide or timolol with brinzolamide. These are good medications which you can use instead of prostaglandins if you need, or vice versa. If a patient isn't responding to a combination of timolol and dorzolamide, think about prostaglandin analog. You don't always have to add medications. You can stop medication and use a different one instead. For me, I use a maximum of 2 bottles of eye drops for a patient for long-term use. So I wouldn't have a patient on brimonidine, timolol and dorzolamide and a prostaglandin analog. I would just use 2 of those medications, and if they're not complying or the disease is progressing, I would then proceed to surgery if that was necessary. Often we see patients coming in, with 5 bottles of drops. So they're on 3 glaucoma drops, they're on anti-allergy drop and on lubricants. And the patient is not going to use 5 bottles of drops regularly or appropriately. I mean, I certainly know I couldn't, so I doubt they could. I think also it's important to be aware of generic medications. So medications that aren't made by the original Western brand. Often the effectiveness is not as good as the original formulation. So I would always stick with the original product. We're lucky here we have access to these medications, so please try and ensure patients get the original article. As I mentioned before, thinking about compliance as a cause of blindness still in our patients, always discuss compliance actively with the patients that you see. Actively raise the subject. Don't be judgmental. Give the patient the opportunity to admit they're not using medication properly, and allow them to admit they're not using it. Ask about side effects, etc., so that you can maybe adjust their medication if necessary. I think treatment strategies, I already mentioned this. And also Dr. Hisham mentioned this, you want to have at least a 30% reduction from baseline with any medication you use, and ensure you get that with the medication. Otherwise, you should stop medication and use a different one instead. I think also it's important to preempt a spike in intraocular pressure. So if you're giving a patient, for example, intravitreal anti-VEGF injection, and the patient's also got high pressure, give the patient acetazolamide or mannitol before the injection. Don't wait to give them the high pressure spike and cause more optic nerve damage. So preempt a spike in IOP, either with oral Diamox or with, for example, alpha-GAN or iopidine to reduce a spike in pressure. This also goes for glaucoma surgery. If a patient's got high pressure before glaucoma surgery, I'll give them mannitol and Diamox. And also even with patients with cataract surgery with a short axial length, also I'll give preoperative mannitol and Diamox to soften the eye and to make the surgery more safe and easier going. Obviously be aware of significant renal disease, sulfonamide allergy and heart failure. It's important to admit defeat. So if a patient's eye pressure is not controlled, or if their visual fields or OCT are progressing rapidly, then you need to move away from medication and progress to surgery, whether it's traditional trabeculectomy or some of the more microinvasive glaucoma surgeries that we have available to us now, with perhaps less effectiveness, but certainly less side effects as well. So we can use these treatments earlier in the spectrum of disease. So these are available to us. I think it's important to think that overall, I've seen more patients lose vision from progression of glaucoma than I have lose vision because of complications of glaucoma surgery. So glaucoma is more damaging normally than the surgery or the procedure itself. So now I'll look at some case studies of patients, just trying to illustrate some of the points we've mentioned this evening. And we can also talk about and share some thoughts on these case studies after the presentation. So this first patient is a 44-year-old Indian male with ocular hypertension. He's a patient who's emmetropic with open angles on gonioscopy and full visual field. So this is an ocular hypertensive patient. His pressures at presentation were 35 in the right and 19 in the left. So I initiated latanoprost therapy. That only reduced his pressure to 27 and 17, which was a 23% drop. So in this situation, I think many people would have added a medication, but instead I decided to stop the latanoprost and switch into a different class of medication. So in this case, it was bronzolamide with timolol. So combination therapy. I've not seen the patient back yet since switching medication. But I think in this sort of situation, when you've got a poor response to the initial therapy of 23%, rather than simply adding treatment, I think we can stop the initial treatment and change to a different class of medication, and that may be sufficient. And then they can just use one bottle of eye drops. The next patient, moving up the scale, this is a patient with primary open angle glaucoma. Again, a young patient, only 33-year-old Emirati male, so a young patient. Traditionally, glaucoma often affects elderly patients, but in young patients, it's more severe because they've got long to live with the disease. Now, can I use my pointer? I can, how exciting. So the reason I've got a picture of a rifle here with a bayonet attached to the end of the rifle is this is how we describe the curvature of the blood vessels as they go over the rim of the optic disc. So this is called bayoneting, when you see this acute angle of the blood vessel, which is similar to the bayonet on a rifle. So you can see bayoneting here inferiorly in both optic discs on color photographs, which is also reflected on the patient's OCT. So on the OCT, you can see inferior loss and flattening of the normal nerve fiber layer, which is consistent with the disc photographs. So this patient's got open angle glaucoma. Vision was 20/20, IOP was 15 in both eyes, so good IOP. He's a -8 myope, open angles. When I saw him initially, he was on timolol dorzolamide, brimonidine, tafloprost, and Artelax. That's 4 types of medication. He was very unhappy, red eyes, very intolerant. So although his pressure was great, I thought, well, I'll just try reducing the medication. So I put him just on latanoprost on its own, monotherapy, and his intraocular pressure was almost the same. It was 16. So patient a lot more comfortable. These are his visual fields in 2017, and they're the same in 2020 as they were then. So no progression, good IOP control, and he's just on 1 bottle of drops. So rather than adding medication or doing anything dramatic, sometimes reducing medication can help patients and improves their compliance and ultimately their IOP control and visual field preservation. So thinking about his visual fields, you can see here he's got classic glaucomatous visual fields, a nasal step. So this is his right eye, this is his left eye. You can see a nasal step on his left visual field and a superior arcuate on his right visual field, obeying the horizontal meridian. And this corresponds with his inferior nerve fiber layer damage on the pictures and also on the OCT. So this is a sort of classic case, really. The next patient is a patient I saw recently, a 51-year-old Azerbaijani female with pseudoexfoliation. I've only been seeing her for a few weeks. She was seen elsewhere in the UAE with pressures of 45 to 50 only just 2 or 3 months ago. So very recently diagnosed with glaucoma. Unfortunately, she's got severe glaucoma at diagnosis, only 51-year-old patient. You can see here, as Dr. Sham was mentioning earlier, complete obliteration of the OCT on both eyes. So this is like a sort of floor defect. So OCT will not be helpful in this patient for monitoring progression. And really we're going to have to rely on visual field assessment. So both eyes have got severe glaucoma. So the disc photographs correspond very well with the OCT images. You can see huge, very large cut disc ratio, and there's inferior excavation and loss of nerve fiber layer tissue here, also on the left eye as well. The patient had a right RAPD because on the right eye the patient has got pseudoexfoliation, which is why the disease is even more severe in the right eye. But also they've got narrow angles, so it's a combination of angle closure glaucoma with pseudoexfoliation also in the right eye. So presenting pressures were between 45 and 50 elsewhere. When I saw her, pressures were 20 and 19. She was on combination therapy of brinzolamide, brimonidine, and travoprost. But again, eyes were red, injected, very uncomfortable, very irritable eyes, very photosensitive. So it was unlikely she would use the medication long term. So I switched her medication to travoprost and also timolol brinzolamide. So rather than using brimonidine, I switched it to a combination of timolol with brinzolamide, which I find better tolerated long term than brimonidine. So they're still on 2 bottles of eye drops, but much less eye irritation, slightly reduced IOP, 15 in the right and 16 in the left. So slightly better IOP control, but importantly, reduced ocular surface disease, so less injected eyes. On the previous images, you can see the right disc is worse than the left disc. The patient's got a right RAPD, and that corresponds, the right visual field is worse than the left visual field. So the right field is here, and you can see that's got severe damage on the 30-2 visual field test. And this is similar to a previous visual field you had done in Turkey. So once I finish my talk, I'll also ask comments from my colleagues about these cases, particularly this last case, because the question I have to myself is, in a young patient like this, should we be happy with a pressure of 15 and 16, or should we be advocating trabeculectomy with mitomycin C? So I think just before I finish, this is a very useful schematic to think about patients with glaucoma. All of the patients that we see, we can think about these parameters and then decide, does the patient require a high target IOP or a lower target IOP? So think about the glaucoma damage. Is it early or advanced? If it's advanced, you want a lower IOP target. Is the patient got a long or a short life expectancy? What was the initial IOP? As Dr. Hisham said, the untreated IOP is very important. If it's a very high IOP, as with my third patient, perhaps we can have a higher target IOP. But on the flip side, the patient is relatively young with hopefully a long life expectancy. So that would lead you towards a lower target IOP. Additional risk factors to exfoliation, secondary glaucomas, uveitic glaucomas, also I think angle closure glaucoma is also higher risk of severe disease, and also the rate of progression. So if you have the luxury of time and lots of visual field testing, then we can look at the rate of progression and the likelihood of blindness within the patient's expected life expectancy. So try and individualize treatment, and also bear in mind the corneal thickness as well when diagnosing these patients. I think in summary, it's very important that in order to reduce the incidence of blindness from glaucoma, we optimize the medical treatment we prescribe to help the patients that we see on a daily basis. So thank you very much for your attention, and I'm very keen to hear my colleagues' thoughts on these cases this evening. So Dr. Omnia, Dr. Hisham, do you have any thoughts, particularly on my last patient who's got severe disease? Would you progress to trabeculectomy?
Actually, I would go for surgery.
Yes.
I would go for surgery because it's we need a real low IOP. So I think maybe surgical solution will be much better because she's taking lots of medication, and we're not expecting more reduction of IOP with more medication actually. But if she has a stable visual field, I think we can just keep on the treatment. How old is she?
So she's a 51-year-old Azerbaijani female, very fit and well. So hopefully a long life expectancy, but with severe glaucoma at presentation, at diagnosis. She was diagnosed just the last 2 or 3 months. So I find these patients quite challenging. So she's got, I'd say reasonable pressure control, 15 and 16. In some ways, some people would advocate, as you say, trabeculectomy, and I may well do that. But equally, if her fields are stable, but then if we wait too long to see if the fields are stable, then we've sort of missed the boat.
Yeah, that's true. Actually, because if she misses a few days of her medication or a few months of her medication, which can happen with any patient, this would be disastrous for her. So I think it's the surgical management is much more, at least for one eye, it's much more acceptable for her.
This is actually a surgical glaucoma. So even if she's we have the target IOP of 15, or she's around 15, 16, we know that she will end up by having surgery one day. We are only gaining time, I think so. And if she has this pressure, it looks surgical glaucoma. I think I will go for surgery, at least for one eye, as Dr. Mohammed he said.
Thank you. That's very useful. Thank you very much. That's very good.
Yeah, thank you for your amazing talk, Dr. Bacon. I think it's very important, this webinar. Thank you, Allergan, because we need to discuss many points here, or we discussed already many points, and most of glaucoma patients are seen and managed by general ophthalmologists and by ophthalmologists from other subspecialty, I think so. So maybe we have to highlight some points for our colleagues who are with us today. I'm totally agree with Dr. Bacon when he said when patient is on 3 medication, this patient is uncontrolled and he might need surgery, or we need to think differently. So this message, we have to address it very well, as we are seeing actually many patients on 3 medications. Most of the patients coming to us, maybe to the glaucoma specialist, little bit late and already on 3 medications. And patient, when he has a lot of drops, they will end up by not using them, or use some and not all of them. So just if we can send this message again to all our audience, that if your patient already on 3 medication, it's mean that you have to think differently. And we are operating our patients late, I think so. I don't know, what do you think, Dr. Bacon, about that?
I think Absolutely, I agree with what you're saying. We're operating we see the patients a bit too late in the disease spectrum, and then we have less to gain by operating. We still have to do the operation, but if we'd intervened earlier, that would have helped the patient more. I agree with what you're saying.
And my question to you actually, are you switching between the prostaglandin?
Not very often, to be honest. The tafloprost, if a patient's on tafloprost, I may try one of the other three main prostaglandins, travoprost, latanoprost, or bimatoprost, because sometimes I feel it has slightly better efficacy. But the other three main, latanoprost, bimatoprost, or travoprost, I wouldn't switch between personally.
And Dr. Mohammed, are you switching between the prostaglandin?
No, actually, I don't that much. Tafloprost is, in my opinion, although they are disputing this, is slightly has less effect than the others. The others have, like Lumigan now has less side effects, redness and so on. The monoprost, the new one, monoprost, I think it's very effective, and I think it has a lot of potential if we just try it. Travatan has redness, but it's you don't have to keep it in the fridge. So everyone has its own privilege, but I wouldn't change actually. If I'm not expecting too much difference if I'm changing from Lumigan to Travatan.
I'm switching actually between prostaglandin.
And
Yeah, I don't know, but I think so. I have some good results with some patients. Maybe the tafaloprost, I agree about the tafaloprost. If I have latanoprost, still I can switch to travoprost or bimatoprost. I think bimatoprost is stronger than all of them, so I can switch sometime to that molecule. But if the patient has irritation from any one of those prostaglandins, so I don't switch, actually. When they have intolerance, so they have intolerance from all prostaglandin.
Yeah, I agree. Yeah.
This is what I'm doing actually, but I give chance to switch between prostaglandin. Yeah, and yes, I would like to ask also Dr. Mohammed Hisham about the progression. We have here one question, by the way, for Dr. Mohammed Hisham. One of our colleagues asking if the visual field progress within 2 months. So what's the frequency of follow-up?
Yeah, actually, he said two visual fields showed progression.
Yeah, 2 visual fields.
Yes, actually, as we said, 2 visual fields are not enough, because maybe on the third one, I answered him, maybe on the third one, you'll find the visual field has improved, because there is a learning effect of the visual field. So we have to have at least 5 to 7 visual field before deciding that this progression is true or untrue. Usually the first visual field is worse, the second, first visual field is worse, the second is better. And there are factors, other factors like dry eye. If the patient has dry eye, if the patient is coming for work and is not concentrating too much, it's subjective. It's actually subjective, not objective test. So it's very hard to depend on only 2 visual field. My opinion is just take more than 4, 5, 7, 6, 7 before deciding, because you're just like a judge. You're judging this patient is controlled or uncontrolled, and accordingly you will make a sentence that he will have surgery, have another medication, or have something like that. So I think it's wiser to be
repeat the visual.
Yeah.
And what about that? We have a lot of colleagues also, they don't have access to the visual field, and they have glaucoma patients. So what do you think about following patients only on OCT? What do you think about that?
I think that's not really acceptable. I think you have to have patients having visual fields and OCT in combination. If you haven't got access to visual fields, they should be seeing a glaucoma specialist, either local to them, or patients often are happy to travel throughout the UAE for treatment. So if you're seeing glaucoma patients, they need regular visual fields, at least every 6 or 12 months.
Yeah, this is very important. That visual field, we cannot just jump over the visual field. With all glaucoma patients, they have to have visual field at least once or twice per year.
I agree, yeah.
Yes. Yes, Dr. Mohammed Hisham, how you are following the progression in myopic patient and in severe glaucoma patients? Severe
Yes.
myopia. And,
Yeah, as we said, in myopia, sometimes OCT is very deceiving, and visual field may be very deceiving. But the progression will show. The progression will show that if this is a glaucomatous visual field, or is this visual field or an OCT results from the tilted disc, or from the glasses or the rim of the glasses, or something like that. So follow up with more frequent visual field. I think this is more logic. More logic.
I agree also, as you're saying, about the progression will show on serial visual field assessment with patients with high myopia. I think the challenge with these patients is the initial diagnosis. I think I don't use OCT for diagnosing these patients. I think it's more important to dilate the patient and have a good look at the optic discs with a 78 or a 60 diopter lens, and do a good disc examination and look at the quality of the nerve fiber layer yourself with direct ophthalmoscopy or indirect ophthalmoscopy, and really assess the discs and look for symmetry or asymmetry and look for notching on the disc. So a good disc examination with a patient who's dilated, I think is important for these patients with high myopia.
Dr. Baker, you talk about the generic medication, anti-glaucoma agents. So I don't know what if you can explain more about the generic medications. It's about the side effect, it's less effective.
I think both, unfortunately. I've seen patients who have said they're on timolol, for example, dorzolamide, and it's the generic. So it's not made by the original company, MSD, or prostaglandin analog, not made by Allergan or Alcon or Pfizer. And these medications, they don't work as well. Patients will have uncontrolled IOP. If I put them on the same medication from our hospital, which is the branded medication, the pressure is fine. But if they're using, I don't want to name names, but if they're using the non-branded type, perhaps a more locally produced type of medication, it just doesn't work as well. And I see that all the time. I'm sure you've seen it as well. Maybe you haven't. I mean, that's my experience. What's your experience?
My experience is the same, and I used to send even the patient to get the branded medication from outside the hospital if it's not available in the hospital. I don't accept at all to give the patient generic medications, and really we want also to send this message today to take care that such medication they are less effective, I think so, and more irritant. I don't know, Dr. Mohammed, what do you think also?
Yeah,
I have bad experience with those medications.
Actually, in Dubai, that we can write the branded name. In Abu Dhabi, I think you have to write the generic name, and then it's up to the pharmacist to dispense whatever the drops that he has. But in Dubai, so far, we can write the branded name, and the patient will get the branded name. So we don't have this problem like you have in Abu Dhabi.
Yeah, but it's really, I think so. It's thank you, Dr. Bacon, for highlighting this point. I think it's very important.
Thank you.
Yeah, I don't know if we have any other questions. Yeah, if I can say that we have to focus on fixed combination, preservative-free, no generic medications, the 3 points at least when we are prescribing medications to our patients. Yeah. Okay, we don't have more questions. So thank you, Dr. Mohammed Hisham. Thank you, Dr. Bacon. Thank you, Allergan. Allergan, I think so they are the most supportive pharmaceutical industry in glaucoma medications, and they're supporting also all the glaucoma specialists in terms of education, and they were supporting most of the MS Society also webinars. So thank you so much for Allergan for hosting this meeting. Thank you, Dr. Mohammed Hisham. And it's the honor to moderate the session. Dr. Mohammed Hisham and Dr. Bacon, they are the speaker And thank you so much.
Thank you very much to both of you.
Thank you. So we'll close now. So have a good night. And the talk was really amazing and interesting and direct to the point.
Thank you very much, doctors.
Thank you.
Thank you. Thank you.
Thank you. Good night.
Very much.
Thank you. Good night.
Good night.
Bye-bye.